those of you guys that I haven't seen in a while, I'm Richard Marshall, one of the interventional radiologists. I've talked to every single person here, seen almost all of y'all in person / everybody. But thanks for having me to talk. I'm going to talk about interventional radiology. This is the one thing I know stuff about, so it was a good choice. I'll walk you through a few different things. We'll go for a practical talk, and then talk about some data and procedures and things like that. So just for clarity, I do some work for a company called Trisalis. We make a catheter that we use for embolization, and we also have a drug. I'm not going to talk about either one specifically, but I'm going to talk about cancer care, and we use both of those for cancer care. So as you guys know,
you work out of EJ or what?
I work out of EJ, primarily EJ. So we cover ECF and we cover children's. We spend about a day a week at children's for elective cases, but I was there this morning for 2 cases, and I'm sure I'll be there a few more times between Tuesday and Friday. So sporadically. So we're primarily at EJ. We do about 4,000 cases a year there right now. So a relatively busy service, especially for 2 interventional radiologists. But now we have some help. So when we moved there about a year ago, we were in the same situation y'all were in. We couldn't do very much. Now we've got things running a little bit. The private practice group that we worked with decided not to renew their contract. And so we became the 2 interventional radiologists on November 1st, handling that 4,000 cases per year volume. So we brought in some extra help from WestJet, and that's Dr. Galambos and Dr. Dawson, and y'all will see their names. They're both good. But we always say, feel free to refer to Tulane Interventional Radiology if it's something that concerns you, or by name, or give us a call to discuss it if you want. We do full-time interventional radiology. If you ask me to go over an MRI of the prostate, I can point to some things, but I'm not the guru for that. But for IR, that's what I do. So we now have 2 Tulane interventional radiologists full-time there. We have a nurse practitioner, Stacy Duthu, who answers the phone a lot of the times whenever you guys have consults. She's our consult recipient. And we also have a nurse navigator. We have residents, we have students. We've increased our procedure volume since January 1st of last year. We were over 60% busier by the end of August this past year. So it's been a little while since I've counted. But I bet you we're probably closer to 80 or 100% busier. The case complexity has really gone up tremendously. So we do a lot more advanced embolizations, interventional oncology care, and a lot sicker patients with it, especially with our transplant service. We now have a very incredible angio system that does not only angiography, but CAT scan images on the same table. So we can do a lot of stuff with that. And I'll show you some pictures of that. But these are all advances from the last few years. For our inpatient consult service, we don't have an order service. Like, you can't order a biopsy. You have to consult us and give a reason, and the reason for biopsy of a left renal mass or whatever it may be. But that's what our aim is. We want to be a consult service just like you guys are a consult service, just like GI is a consult service. We want to add to patient's care. We want to do an evaluation, tell you, yes, this is something we could do. We should do this type of procedure, whether it's, for most of the things you guys are already going to know. You guys are pretty advanced. A lot of other services don't necessarily know that. But we want to see patients who are complex patients, write a full note on them, full consult, and then add our value to their care. Same is true with our outpatient referrals. We have an ablation tomorrow. That person has come to our clinic and seen us and heard about the procedure, met their doctor. They've already signed consent. They know what they're getting into. We have anesthesia. We're not going to have any surprises. So we're going to do that at 8 o'clock, and we'll be done by 8:45. So that really adds to patient care. And then we do research. We're ramping that up. We have clinical trials. We have one bigger clinical trial going through the IRB that we're going to be the second site for a nationwide study. We are site directors, co-PIs, or co-investigators. We have med students and residents working on that too. So a lot's changing. For our talk here, we'll talk about 3 different parts. So we'll talk about catheter insertions that are relevant to you guys, different types, indications, follow-up, exchanges. We'll talk about interventional oncology, and this is really my area of expertise. What I should have told you was I did my fellowship in interventional oncology. So there's IR. I started actually, I went to Tulane Med School. Did my residency at Ochsner, was exposed to the field of cancer care and minimally invasive cancer care. Then did my fellowship at Cornell and Memorial Sloan Kettering, where I got to do a lot of advanced cancer-related care. So that's what we call interventional oncology. There's a Society of Interventional Oncology. And most people who do this practice probably 50, 70% interventional oncology. And then the rest is like, we put in abscess drainage and do all the normal stuff that you have to do to survive. So we'll talk about IO in the kidney, and then we'll talk about prostate artery embolization. It's a hot button topic right now, but I'll tell you what we know, what our side of things is. So for starters, that's very green. This is the Tulane template. We'll go through a few of these things. So simplifying catheter insertions for the kidney. We do it for blockage of the urinary tract and then leakage from the urinary tract. So that's as simple as it gets. But there are lots of different things within that, whether it's stones or infection, malignancy, or iatrogenic injury. And you guys get a lot of those referrals. And then I was at LSU for a long time and University Medical Center, where we saw a lot of trauma. And so we did a lot of diversion for that. So one thing I wanted to mention for oncology patients, we're starting to do this a little bit more. Patients with preserved kidney function that are getting nephrotoxic chemotherapy, we put in nephrostomy catheters for them so that they can get through their chemo. This is a trend that we're seeing from oncology. We do it for the liver, for hepatotoxic chemotherapy, and I've done it a few times for kidney. Postoperative complications, you guys know all about that. So this is what a nephrostomy looks like to us. So you guys send us a consult, patient comes to us, we put them on the table. We need to get the urine out as quickly as possible. Let's say that this is an infected patient. So when we see any signs of infection as interventional radiologists, we say we're going to do the minimum necessary to get this urine out of the patient or decrease the pressure that's in the collecting system. So for that reason, we put a drain with side holes that drains into a bag. That's the path of least resistance for any type of drainage. We do as little manipulation as possible. So we put a needle in, followed by a wire, followed by a dilator to make that tract bigger. And then the catheter goes in and we suck all that urine out as quickly as possible. I get asked a lot of times to do a nephrostogram for patients who, let's say, come to the hospital. We need to know what their ureter looks like. And sometimes people are really disappointed when we say, we didn't do a nephrostogram. It's not that we forgot, that we don't want to, because patients die from people injecting pressure, and I've seen it twice in my life. People put it in a nephrostomy, it goes great, and then they say, let's check the catheter. Slam in 10 cc's of contrast, which doesn't sound like a lot. That's enough to take pus under pressure and push that lipopolysaccharide into the bloodstream. Patients get septic. One major case I remember was a patient who had pulmonary fibrosis, just couldn't handle a little bit of sepsis. So it's a real thing. So we'll give you some pushback every now and then about that. It's for good reasons. Then we have the PCNU. This is basically the same mold, but it's longer. So the catheter has side holes both in the collecting system. Some of them go all the way down the ureter and then end in bladder. And this is your double J, but with a PCN attached to the end. We love these because we can cap these and give people a trial of whether or not they're going to do well with an internal stent. Sometimes they do, sometimes they don't. We also can give you guys great access in the future. Let's say if a patient has a stone, we can just switch that out to something that you guys can use. And these are our integrated nephrostograms. You can see contrast in the bladder from the left side, or this is the patient's right. So we're always looking directly at the patient. Typically they're looking at us, but when we put them on the fluoro table for a nephrostomy, they're always prone. So it's opposite. And then here's our internal ureteral stent. These are different than what you guys put in. You guys usually use a 6 French stent, correct? Yeah. We start at 8 French. We could get a 6 French, but typically I don't know any interventional radiologists who use a 6 French. These are a little bit more rigid. They're not quite as friendly to the ureter as, let's say, the 6 Frenches that you guys put in. These are great for patients who have compression, but that's not a long-term solution because they can cause erosion over time. But for 3 months, they're fine. They actually make these in much larger sizes as well. If there's some particular patient who needs a bigger one that's a lot stronger for a few months, we can order that. We don't stock them, but we can get that. And we actually have catheters. They're called breakaway. So it's a PCNU that splits apart and turns into a double J. So just there if you need one. They're kind of cool. Long-term management. We always wonder, can the patients urinate? That's why we love to put in internal drainage if we can. But we love PCNUs because we can find that stuff out. If patients walk out of or leave the hospital with a catheter in their flank or inside, we want to change them out every 3 months. We will send all of our internal stents to you guys because for us, we could go in the bladder, but grabbing a stent from within the bladder with a snare under X-ray is a lot of fluoroscopy time. It's a high radiation dose. Looking with a scope, you guys can look right at it and grab it. So we don't have that luxury. The pelvis is the highest radiation point of the body because we have big iliac bones. It's very dense. And so, 20 minutes of fluoroscopy several times a day adds up to a lot. So we try to minimize that. But for anybody with a nephrostomy, every 3 months. PCNU every 3 months. And that's because they'll become encrusted in salts. If patients have mucus, let's say it's an ileostomy patient, we might want to do that a little bit sooner if there's a lot of mucus because it can clog the catheters. And certainly if anybody demonstrates that they're going to clog sooner than 3 months, we'll just bring them back in 2 or 1. There's a patient who probably is still at UMC who has a retrograde transcystic PCNU. So it goes into her bladder and then goes up into her left kidney. And she was getting an exchange every 6 weeks for the last 5 years. I don't know if you guys have come across her. She's very interesting. She had viral cystitis and basically scarred her bladder, and she doesn't want an ileostomy. So she was getting this catheter. So every 6 weeks she comes from Baton Rouge and has a catheter exchange with us. She gets 2 of her set of 1 fentanyl, falls asleep, and we can do the exchange before she wakes up. All right. Percutaneous access pathways. This is Brodell's avascular plane. Do you guys talk about that? Okay. I thought we were the only ones. We always try to put our nephrostomies in through this plane. It's the same whether we're doing a nephrostomy or if we wanted access for PCNLs, or if we want to put in a PCNU, we always try to go through that. We have some principles, as I mentioned. We want to avoid sepsis in these patients. We always inject less contrast than we removed. So we don't want to increase the pressure within an occluded collecting system. We minimize wire manipulation because all that can cause bleeding. It can cause, it can push bacteria into the bloodstream. And then if patients have any signs of infection, we avoid an integrated nephrostogram. We have a low threshold of sending patients to the ICU. We'll actually start infusion of saline in the procedure room if the patient's heart rate goes up whatsoever, because we can avoid going to the ICU by early goal-directed therapy or treating with saline boluses right away in antibiotics. But we appreciate all of the help that you guys give us with those patients because they do get septic. This is our first case. It's a 59-year-old female. She's obese. She has occluded internal ureteral stents and she's septic. You can see she actually has gas in both of these collecting systems. She was not manipulated recently. So we were cautious with this individual. So we put her prone on our table. Most of these patients get moderate sedation, so Versed and fentanyl. The ones who are really sick, we just do local anesthesia because we don't want them to throw up. We don't want them to have any reactions whatsoever. We don't want to drop their blood pressure. So this is a good look. Up here, you can see how my ultrasound probe is oriented. So this is oriented parallel to the lowest rib. That way you can see everything in your field of view. If you put it perpendicular to the ribs and they're in the way, it shadows out, and you can't see between them. So this is a nice view of the kidney. It's almost a lateral view, like a crossways here. So I find where there is dilation of the collecting system. So I look for black fluid, and you can see that black fluid. Let's see if I can use this pointer. Nope. Oh, there it is. So right here is a calyx, and this is renal pelvis. So this is my target. I want to avoid going through as much fat in the hilum as possible because that's where blood vessels are, right? Artery, vein. So we put a needle in. This is, if you can see, use your imagination, that is my needle coming down like this. And that's the tip of my needle going into this fluid right here. So once I put that in, here you go. You see the video of it there. And that's a wire going through the needle. You can't see very much other than it's in the black stuff. And then we switch to fluoroscopy. So I have two things in here. One of them is the catheter right there, and there's our cope loop. And then this is a safety wire that's alongside it. So what I did was I put a wire in initially, put a sheath over the wire, pulled out the inner dilator of the sheath, and then added another wire. So I've got two wires in there. And then using the second wire, which is a much bigger wire, it's an 0.35-inch wire, then I push in this 8 French nephrostomy. And I'm injecting about 3 cc's of contrast here, so not very much. This is another patient, 69-year-old female with a GYN malignancy. She's got bilateral hydro and sepsis. Much more dilated. You can see this hydro from anywhere. And so no fat between the renal parenchyma and this fluid. There is fat on this side. Good thing we're not going from that side. So we'll put a needle in, and there's the tip of our needle entering the fluid. And here we are. So I really use very little fluoro to do these. Just put wire in, dilate over the track, put our nephrostomy in, form it up. And by the way, we form, when we people say pigtail drain, we call this a cope loop locking nephrostomy. Dr. Cope came up with the whole string on the end of the catheter. When you pull it, it forms a curl. So that's what you'll hear in our world. And if you say, if people say throw a pigtail in there, that's when the radiologist, interventional radiologist goes, oh, fingernails down a chalkboard. So that's your run-of-the-mill PCN. Transplant nephrostomies are actually, you see a lot better with ultrasound because it's closer to the skin, so they can be more straightforward. Access for lithotripsy. This is very similar to a nephrostomy or a percutaneous nephroureterostomy, but we want to hit the stone with our needle. So when we provide access, we're going to look, we're going to identify the target. We're going to make sure we're not going through any bowel to get there. So preoperative imaging is very important to us. We want to know, is the intestine close to where we're going to access? I.e., we don't want you to put your 30 French trocar through colon. And then we're going to puncture as peripherally as possible directly into the stone-containing calyx. If we can do that, we want to avoid going into the hilum because that's when you guys would put your scope in and see blood. So that's not good for our business. So here's our case, 56-year-old male with a residual right lower pole calyx, lower pole stone. It was about 14 millimeters. He's got a stent in there already. And so upper pole access was requested. So here's the stone on cross-sectional anatomy. We are not going for the left side, which is very dilated. We're going for the right. So this is a close-up, and I'll show you the ultrasound. So that's what our ultrasound looks like of the same area. So we're just getting a little slice of this kidney. And you can see there's a little bit of hydro there. There's some dark fluid within the collecting system here. And here goes our needle. There it goes. So there's the needle. And you see the tip of the needle in the collecting system here. And this is a dilated system because there's a stone obstructing it. So that was the lower pole by the stone. And so then we went for an upper pole access. This is called a tandem stick technique, or you stick one, you inject contrast, and it fills up the rest of the collecting system. And a lot of our PCNL patients, you guys do a great job of putting ureteral catheters in beforehand so that we can do this. We can either inject air or contrast. Dr. Ezel, my colleague, is the queen of injecting air, which floats up, and then she sticks the air bubble. So she gets the most posterior calyx possible, and she avoids sticking arteries. So this is me pushing a sheath in. So that little ring marks the end of my sheath. And I had trouble getting that wire to go down. And if I pulled my wire out and the tip of my catheter wasn't quite in the collecting system, then I had to start over. So I used a second wire and maneuvered that one down into the bladder. So we're kind of pushing and twisting the wire until it goes. And there you see it go. So then we pushed everything down, pulled the first wire out, and there's our sheath following it. This is the patient afterwards. So stone's gone, but then there's this fluid right here. So this patient, I think she just drank one of those big gulps. That's her stomach full of fluid, and she's got a right-sided effusion. So right-sided effusion after PCNL, what do you think about? Two things.
Pleural injury.
Pleural injury, yeah, blood or urine. So this was published, and they added me to the publication, but I only found out after they had submitted it. It was one of my complications. I didn't really appreciate that. But we knew going into this that transpleural punctures were a risk. But this patient, we wanted to provide access to get this stone out since it was a redo. So you can see this is the patient. This is a CT scan with the patient breathing in as much as they can. And so the diaphragms are being pushed down. But when this patient was relaxed, the diaphragms were up. And so we punctured through it. But they had a big leak from the access tract here going through the pleura and then into the pleural space. So we put in a chest tube. This patient wound up actually getting a pleurodesis and a decortication via VATS. So it was kind of a big deal. But she had no stones after. So now, interventional oncology. Have you guys ever heard of the term interventional oncology? No? Okay. Now you can spread the word. So we'll talk about a few things: biopsy, ablation, and embolizations, among others. So biopsies. You guys send us biopsies all the time. People ask me questions. By the way, patients' concerns whenever you send us a biopsy, or anybody, they want to know, is this going to hurt? And the answer is, we're going to give you some sedation. We're not going to knock you out all the way. But everybody wants to be knocked out. We say, no, we're going to give you two medications that'll make you feel just fine. You won't care about me at all. I'll give you numbing medicine. We'll go through the numb area, and then you won't feel a thing. And then the other thing, the astute patients say, well, if you go stick a needle in there, what's going to happen if it's cancer? Are you going to spread it around? And the answer is maybe. So there's about a 2% incidence of sarcoma tract seeding. That's the highest tract seeding incidence out there. And we prevent that by using the trocar technique. Everybody who gets a biopsy, with the exception of maybe less than 1% of people who just can't tolerate the size of the trocar, like somebody whose INR is 3, but we need to diagnose their liver cancer prior to transplant. Never a kidney patient. So we always put in a trocar, and then we can do fine needle aspiration through that, or we can do core biopsies. We can do as many as we need to without the risk of tract seeding, because we're going in and out through a needle. So I think patients need to know that stuff. For high-risk patients, it might bleed. 22 gauge fine needle aspiration. We can go in and out as many times as we need to and get an answer. That's not a whole lot of tissue, but oftentimes it's enough to get us, yes, this is, this is a carcinoma. For cores, if we want to do genetic testing, that's what we have to submit. But that has to be a patient with a platelet count that's greater than 50,000, INR less than 2.
Just to point out for everybody, the third author of that paper. Oh,
Wow.
what was
Is that really you?
Yeah, that is me.
Great paper. How about that? I had no idea. I only look at the first author, I guess. No, I know that's quite a feat. You made it into one of my talks. It must be really good. So here's an example of a renal mass biopsy. 73-year-old guy with hematuria and renal dysfunction. He had a non-contrast CT, and we were going after this exophytic mass. Our definition for exophytic is 25% or more outside of the kidney, so outside of where the normal kidney would be expected. So here is, I do as much as I can under ultrasound. Here's his ultrasound. We've got a big mass, and that is the mass right here. There's a little bit of normal parenchyma along the outside. So we call this like the bear claw sign, where it looks like it's being held. And then this is normal kidney, and that's renal fat, hilar fat. So we measure it. This is pretty big, 6.8 centimeters. And then we show the vascularity around the edges. So that's normal renal vasculature right there. So I choose a spot to go in where I don't see a lot of blood flow. And then I always want to go in through normal renal parenchyma because normal kidneys have normal kidney arteries. Cancer has dilated arteries that are on VEGF, EGFR, steroid level cytokines. So they can't constrict if you damage them. So here's our needle going in. And this is a fine needle aspiration. So I put a trocar needle in, and then I go back and forth with a 22 gauge needle, impaling cells. We get enough cells that we can spin it down and form a clump. It's called a cell block, and then pathologists will look at that for us. We can do genetic testing on cell blocks, but it's not always successful. So other times we'll do a core. So that's an image of the core biopsy being done. What you see is bright stuff from microscopic air bubbles in there whenever we fire it. And the core, this is a true cut. True cut is another one of those chalkboard words for interventional radiologists. I like the Bard Biopsy system. It's a totally different brand, but this air is introduced so we can see where the biopsy is being done. We can also see the tip of the needle, but that's an 18 gauge core. That's our standard. And then we usually will plug the tract. So we take a little piece of gel foam and we roll it up into we call it a torpedo. So it's about 1 millimeter in diameter. And we put it in a syringe and we inject it through the trocar, and it plugs up the hole where we did the biopsy. And that really dramatically lowers the rate of hemorrhage. So from about a 5% incidence of hemorrhage post kidney biopsy that's clinically relevant to about a 1%. So pretty good. And then there we are 2 hours later. I'll often do a follow-up ultrasound just to make sure we don't send a patient home with a giant hematoma in their flank. All right, this is where I like to get to, renal mass ablation. So this is, you guys probably know this really well, part of the NCCN guidelines. AUA has guidelines on this that are very similar. This is what we typically follow in IR. If you guys have preferences on how you want us to treat patients, let us know. If you want to use a different system. But we focus on stage T1A renal cell carcinomas. Those are less than 4 centimeters. They're confined to the kidney. We prefer for them to be as peripheral as possible because we don't treat the hilum well at all. And I'm going to show you an example of that. So the ideal patient for us is someone who we don't really care about their kidney function because we treat very little normal parenchyma. It's not to say we don't care at all. But part of our advantage is we're nephron sparing. We also want people who can survive the sedation. We love to use anesthesia. It makes our ablation easier because the patient's not moving around at all. Let's say, I give one of you guys 4 of Versed and 200 of fentanyl. Some of you are going to be out for an hour. Others are going to say, when are you going to start the sedation? Or you're going to start moving around and say, the oxygen's bothering me, and you're going to start wiggling while I've got a needle in your flank. So we like for patients to be able to be under general or at worst a MAC. And METs to the kidney are not good targets for ablation. They're not well encapsulated. when, I don't know if you guys have ever taken out mets to the kidney. I've done it once. I did a colorectal met, and it was a fantastic ablation, and the guy recurred. I mean, I had like a 1 centimeter margin. But we are not the right answer for met ablation. I think, if it's a last ditch effort, maybe so, we can talk about it, but that's not a routine thing. And there are principles in NCCN guidelines for how we do what we do, which is fantastic for IR because we are traditionally all over the map when it comes to different procedure techniques. So this is very standardized. So you guys are going to get what you get, whether you go to Tulane or if you go to Lake Charles or Shreveport, it's all going to be fairly similar. Follow-up after ablations, same as partial nephrectomy, almost exactly the same. So we'll follow patients for 5 years, typically with annual imaging after the first year, but then, so we started 3, 6, and then 12 months and then annually thereafter. And then we get chest CTs every year, and we check kidney function. So here's our first case. This is a 71-year-old lady with an enlarging right upper pole renal mass. It was 3 centimeters at the time of diagnosis. Most patients come to us with with just an imaging diagnosis. A lot of times we'll get people requesting a biopsy at the time of the ablation. That's fine. For really small masses, so like a 1.5 centimeter mass, our biopsy trocar, or our biopsy length is 2 centimeters. So 1 centimeter or 1.5 centimeters is smaller than that. Point is, that's a very small mass. If you do a biopsy of that mass and you get a hematoma, which is possible, it can ruin the ablation. So for really small masses, if it's not going to have any clinical relevance, we're going to call it renal cell carcinoma, NOS, then we would like to just do the ablation. So sometimes we'll make a decision after we put in the ablation needle to do the biopsy alongside it. If we get it, great. If we miss it, we miss it. For anything larger than 2 centimeters, no problem. If we get a little hematoma, it's not going to obscure the lesion to the point where we can't see it. So if you see right here, this little bump, that's the mass. So put an ultrasound probe on it. You could see it very easily. It's 3.4 centimeters. So I set up my needle entry for this one because it's going, it's creating definitely a hump on the renal margin here, but it's going toward the hilum. So for this one, we chose cryoablation. Cryo is a little bit friendlier toward the renal collecting system. So it's not going to cause as many strictures as, let's say, microwave or radiofrequency ablation. So colder is better. Heat or hotter is definitely harder to, we've seen strictures with that, and we do cause kidney dysfunction because of that.
You doing IRE for these?
We are not. There is a newer system that's a single probe for IRE, but the ablation volume is very small. The traditional IRE, so like the nanoknife or nanopulse nanoknife, it requires needle insertion 1 centimeter apart in a grid fashion. For us, going so deeply from the skin down into the kidney, it's very tough to get all those probes to line up in parallel because they're smaller. Do you guys use it?
So I've used it on prostate a ton.
Yeah.
I used to work in Miami. They have a huge interventional.
What's his name? Raj? Yeah.
Spectrum, the whole anyway. But but he does a ton of IRE and specifically for like central lesions, things that are close to the ureter, etc.
He has great outcomes. His outcomes are not replicated across the country. And I'm not saying the point is he's outstanding. That's his thing. That's what he does. We have not done that.
Is that the Raj Narayan? He used to be at UM. He was at University of Miami. Now he's at the Cancer Center. I used to learn that.
So for this guy or lady, we put in 2 cryo needles. These are connected to a big machine. It gets really cold really fast, negative 40 degrees Celsius is what we achieve. So these are our 2 needles inserted almost in parallel into the tumor so that when it freezes out from the needles, we're going to cover the entire mass. it freezes from the tip. Think of it about the tip back. So that's a nice convenient thing. So you put your tip in the farthest point away that you want to freeze and freeze back along it. And here's our ice ball forming under ultrasound. So the ice creates a shadow. So here's a smaller ice ball and then obviously a larger ice ball. And that's the needle going into it. And you can see on CT, here is a, let's see. This is the normal density of the kidney without contrast. And this is a very hypodense kidney back here. That's what it looks like when it's frozen. It's kind of cool. You can see the margins of where you're freezing very well. The outer margin of the ice ball does survive. It doesn't quite get as cold. So it gets to about 0 degrees. We want to get to -20. So that's about 2 or 3 millimeters in from the ice ball. And there's the ice ball getting a little bit larger. And then this is the post-contrast CT. It doesn't project very well, but there's enhancement here. You can see the cortex enhancing very well. Not quite as well over here. There is some edema, but there is a darker area here. It's hypodense because there's no contrast entering it. And so that whole area is dead. The patients can experience fever after this, very low-grade fevers. They typically have some discomfort, but these patients go home from the hospital 2 hours later, and we send them home with pain medication, and they generally do pretty well. Microwave, which is this next case, is more uncomfortable. So sometimes I'll inject lidocaine and bupivacaine around Thurot's fascia to try and help with that. So this is a 48-year-old male with an enlarging right renal mass, concerning for renal cell carcinoma on imaging. There it is. I did that. The purple. So same concept. We're going to put a needle into the mass, but there was some bowel that's not too far away from the kidney. So you see that right there, that's colon. So what we did here was we put 2 needles in. One of them, whoops, I'll just tell you about it. One of them was going into, it goes into Gerota's fascia, but it's between the colon and the kidney. And then we inject saline with contrast in it. If you put just regular saline, it looks like hematoma and you freak out for the whole case. But this is to push that bowel away from the kidney. So this is how we can ablate anterior renal masses. We can ablate things that are close to bowel. We can ablate things that are very close to the abdominal wall and preserve those muscles if we burn a little too much or freeze a little too much.
You said you preferred using cryo versus heating the areas. What's the reason for that?
I prefer I'm more facile with microwave because it's a smaller needle and I've done way more cases with that. Cryo is a little bit more forgiving as far as getting into the renal hilum. So we don't see, if you were to microwave in the renal hilum, then you get a stricture. Microscopic gas bubbles will go through veins and they will cause those veins to thrombose. So you can see strictures not where you treat it, but several centimeters away. So if I can avoid that, I do. We actually don't have cryoablation at EastJet. And a lot of centers will go just for one versus the other. So they'll buy a microwave machine or they'll buy a cryo machine. They both have the same long-term outcomes. Cryoablation has a slightly higher incidence of hematoma formation, about 8% hematoma formation, whereas microwave has almost 0, like 1 or 2% hematoma formation. And the microwave nowadays is very reliable, so that's what I like to use.
So it's the adverse effects.
Yes. Yeah.
Is there any, totally random, is there any difference in cost to the patient between them?
No.
Like if you're concerned about stricture closer to like the collecting system, doing cryoablation is beneficial, it's no difference in cost.
No difference in cost. The CPT codes are similar. It's cost to the institution if you buy the machine. If you buy a machine and don't use it, then that's a huge cost. Most of the time now we can rent these, and we are going to do that at EastJet.
Going to rent the cryo machine.
Yeah, but we have many things we're working on right now. That is on the list. It is not the top. So that's in our future for sure. So this is follow-up 6 months later. There's a little calcification in there. that was present on pre-imaging. But it looks good. There's no, this is scar tissue. It's not enhancing whatsoever. So when we look at post-procedure imaging, we are looking for enhancement. If you tighten the windows up, meaning that you make the whites, the light colors brighter and the dark colors darker, what you want to see is between phases, so between the non-contrast phase and the contrast enhanced phase, is there any change in density? So that's what we look for. And we do want a margin around there, so it should be a little bit larger than when we originally started.
If on the follow-up imaging, you do see something that is either, maybe you didn't get all of it,
Yeah.
or maybe there's recurrence, how soon after you do the initial, can you do a second?
So we could do it right away.
Oh.
I image at 3 months post, and so does Dr. Ezel. And we have that protocol because we know by 3 months, the inflammation should have resolved. So inflammation enhances, right? So you don't want that to be a red herring and lead you to think that there's more cancer there. So our first round of imaging is at 3 months, and we will retreat right after 3 months. Now, I'll tell you, microwave ablation has a recurrent or a retreatment rate of about 2 to 3%. So pretty low, pretty rare. But I'll show you one where we might, where we needed that.
Right, you mentioned moving the bowel away for
Yes.
interior masses. When you treat the interior masses, are you seeing a higher complication rate?
We are,
Vascular complication?
no, we're not. And I think that's probably because the number that we perform is so low of anterior masses. So I would imagine that there's a higher rate of retreatment because it is a technically more difficult area to reach. But if it's reachable, usually we can treat it without complication. Like, if bowel is close by and we can hydrodissect, then we have plenty of room.
What's the largest kidney mass you've done?
The largest one is, so I stick to T1A.
Only, okay.
Yeah.
I was just thinking of, if you have a patient that has a large kidney mass that is old and has all the medical comorbidities and make you
Yeah.
not want to operate on them, but you're concerned about doing nothing.
Yes.
I was just curious if
So
those situations, if you do anything.
this is a great question because there is a technique that we use in other parts of the body that people use for the kidney. Rarely, it's combined embolization and ablation.
Oh.
So if you preoperatively embolize somebody, you do two things. One, you can start to shrink that mass because you cut off the blood flow. We know that's not a curative thing to embolize it. The patient's not going to do well in the long run if you
Yeah.
just do that. But if you can shrink it a little bit and you reduce the body's own, so we're trying to heat up for microwave, we're at 250 degrees Fahrenheit. So really hot, above boiling. If you are continuously washing that area with 98.6 degree blood, then that's a big cooling. It's a radiator effect. So if you stop blood flow in that area, then you microwave or cryo, same principle. You can actually get a much bigger treatment volume. So that is an option.
But not a bit. I was just, sorry, there was just like one patient in particular, Dr. Coffin, and I saw that had like a 10 centimeter renal mass, but she was like 80 something, had zero interest in surgery.
Yeah.
And we were like, we don't recommend doing nothing because it was big enough that it probably eventually spread. But I didn't know if in those situations, if you guys would be willing to try or if it's even feasible. So
Yeah.
that's why I asked that question.
No, it's a great question. I think if it was a 5 or 6 centimeter lesion,
Right.
I think then that would be
More reasonable, but 10 is.
Yeah, and if you get to 10, what's the difference between if you could radiate and spare the kidney?
We refer to them.
Yeah. I think, no, there's no great data.
If the patient goes in Manchuria, is the patient terminal before you start, if the patient got several years, there's a lot of variables that make you take that decision.
And when we get into tumors that are bigger than about 4 centimeters, the post-treatment fever, malaise, inflammation, systemic inflammation that occurs. Yeah. So when people are older, that's a big deal. Question?
I was gonna just segue into your 2 seconds about protocols for AMLs.
Yes. AML got cut from the talk
I know,
because it would take me hours to go through everything.
I know.
But
Maybe just 2 seconds.
yeah, AMLs are a fascinating tumor. Our traditional way of treating them in interventional radiology is through embolization. The goal for an AML, so the bad parts of AML are the vascular parts of AML. People die from aneurysm rupture in AMLs. So we want to eliminate the vasculature. But there are two ways to do it. You can either embolize with particles. So we put a small catheter in, fill up all the vasculature with small particles until it's occlusive, clot forms, scar tissue forms, and it's treated. It has a really high success rate. I can't quote you the number off the top of my head. But another way of doing it is to inject alcohol or a sclerosant. So we go into the lesion. If we can get our catheter perfusing only that lesion, so not normal renal parenchyma, we can inject absolute alcohol, and that will damage the endothelium. So it's protein denaturization. So the endothelium proteins on the endothelial wall become dysfunctional or non-functional. And that artery occludes almost immediately, and it's never going to open back up. So that's the way I like to do it. Alcohol can be painful, so I put people to sleep for it, but it's a great long-term outcome. And then we look for those tumors to shrink over time. As long as they're getting smaller, the risk is, it's never zero, but it's as close to zero as it can be.
Thank you.
You're welcome.
The problem with the AML, of course, is when it is, yeah, that's a big difference.
Yes. And AML size doesn't matter so much for us. So if it's, let's say it's 10 centimeters, it's not that big of a deal because it's a lot of fat, right? The fat's not going to be that big of a deal to treat if you get fat necrosis. So our next case, this guy had Gardner syndrome. It's one of those, he's predisposed to cancers. They typically get, what do they get? They get lung cancers and a few other soft tissue tumors. I'm too far out from med school for that. But he had a history of clear cell renal cell carcinoma. On the right side, he's status post nephrectomy for that. And he now has a 3 centimeter left-sided tumor. This was biopsied, it was clear cell. And this guy came from the VA. He was a great patient. He had, so here's his tumor. And he was referred to me, and I said, oh, I don't know, that's awfully close to the hilum. It looks like it's getting into the hilum. And we talked about it, and there really wasn't a great other option. We talked about systemic therapy, immunotherapy, and this was 6 or 7 years ago, and thought there's not the greatest data for it. I don't know how he's going to do with it. We can always use that after we ablate him, but we think that there's some value in ablation. So I said, all right, I'm not sure I can get the whole thing, but I'll do my best to get it and see if we can cover it. So we saw him in the clinic. We scheduled him for microwave ablation under general anesthesia. And he was all for it. He did not want another surgery because he said he doesn't want to live on dialysis. Anything that puts him closer to dialysis, he doesn't want. So he was well aware of all the risks that we thought existed. So this is his kidney under ultrasound, and this is kind of a cool 3D positioning system. So this is the MRI that he had fused with the live ultrasound. So when I turn the ultrasound probe, it shows me where I'm looking on the MRI. And it does the same thing for PET CT and for contrast enhanced CT. So it's really helpful. And we did hydrodissection for him because the intestine was really close by. Here's the colon. So injected a little bit of fluid, and you can see the tumor is right here. And now you can start to see a little bit of fluid building up along the margin of this kidney. And then there's going to be a lot more there. So that's our buffer. And then we go put our needles in. So stuck one needle into the tumor right here. And this needle, this microwave needle, is designed so that it ablates from the tip and then reflects the heat backwards. So I put the tip right up against something that I don't want to treat, but not touching it, and it's protected. So I put that all the way into to the hilum. And then put a second needle in next to it. That makes the size of our ablation a lot bigger. So we double the amount of energy we put into it. And then, I'm sorry?
You
You have
never
the
cover
VA?
at the VA.
I used to cover the VA a little bit, and then we started covering East Jeff, and the wheels fell apart as we were going down the road. But Dr. Gibbons works there. He's good. Dr. Gibbons covers for us sometimes. at East Jeff, but he does microwave ablations too. And actually, I think he does cryos. I think they have a machine. And then we did a biopsy. And here's us microwaving. And you'll see the gas bubbles developing in there. So that's going from liquid to gas. So it's really hot. And when you see that, you know you're getting a good kill. And that's at the end. So there's our nice gas bubbles. So no clinical complaints 1 year afterwards. His creatinine was stable. His MRI showed post-ablation changes, but I had him come to my clinic so I could review it. And I took a look at it, and this is the dark spot in the anterior portion of the kidney is part of the mass. That looked really good. There's no enhancement in that whatsoever. That's dead tissue. And this stuff is, they're denatured proteins. You know, this is all just kind of functionless organic matter in there that eventually is going to get resorbed by the body, and that scar will get smaller. But this is a little lower down, and this really did not look good. So while there is no enhancement in part of this, this is not the typical appearance of brighter enhancement along the margins. It's very irregular. This is nice and smooth along its margins, whereas this one is irregular. And I didn't like the way the hilum looked, and I'll show you more in a sec. That is not normal. So that's cancer growing into his renal vein until proven otherwise. So we discussed this, brought him in right away, and use our same fusion technology to mark the tumor, which is the T right here. So this is a diffusion weighted sequence. It tells us where water is moving around freely. So it's usually well contained within cells, but in cancer, you lose some of that. So it gets a little brighter in this area. So we marked the T in the computer, and then it showed us where the T for tumor is on the ultrasound. Targeted that with our fine needle aspiration. And there's our needle going in. And here's our fine needle aspiration. You can see the little needle going in and out. Aspirated some cells, gave them to the cytopathologist who was on site, and they said, you got good stuff here, which is never good. So this confirmed it was carcinoma, and he went on to receive immunotherapy. He actually died of lung cancer 5 years later. So we didn't hurt him that much. Maybe we helped him. It's never a great thing to go for that, but at least there's a silver lining. So which modality is best? We talked about it a little bit. Cryo is friendlier for deep stuff. I like microwave. It's a single needle, 17 gauge. It's very sharp, so it's easy to put in. And it's very stiff, so I can maneuver it really well. Radiofrequency ablation is a little bit more cumbersome. But if you guys are ever out in the world and need to select a machine, give me a call. I know a bunch about this stuff.
Do patients feel any different?
Microwave, everybody goes to sleep. because-
Sorry, I meant, it's been like post-op, like, you know.
Yeah.
Do they have like difference in terms of like soreness and pain for like a couple more days with one versus?
So microwave, you can, if you heat the wrong stuff, it hurts worse. But we're pretty good about avoiding that stuff. So like getting into the flank, the musculature of the flank, it'll hurt. If we hydrodissect, we almost never see that. Plus I put a little bupivacaine in the hydrodissection fluid. So people wake up feeling really good. Cryo doesn't hurt while we do it. It's an ice ball. So you can keep people awake when you do it. So let's say that 80-year-old, you couldn't give them, they didn't get cardiac clearance. You could do a biopsy, you could do a cryoablation on it. It will be more sore afterwards for about a week. And about, I would guess it's 30% of patients, they'll have some pretty enough soreness that they'll take the Percocet you give them. Microwave, not so much. Outcomes are all about the same. This has been studied compared to partial nephrectomy, robotic partial nephrectomies. And robotic partial nephrectomy, you know, when you guys are able to take something out and put it into a bucket, we know exactly what we get. We know the margin. We do not have that in interventional radiology. We're pretty good. As I mentioned, we got 97% success rates for first time treating renal cell carcinomas. smaller than 3 centimeters. It's a pretty good number. But it's still not 100. In patients who have kidney dysfunction, I think that's where we start to become really valuable. You can preserve patient kidney function a little bit better. And somebody who's sicker and you want to keep them out of the hospital, we're great for that. But I don't want to make this seem like it's the #1 treatment for kidney cancer. It has its role. There are a lot of patients with kidney cancer, and we treat a lot of these. But we should know that there are ideal patients, and then there are patients who are really well suited for partial nephrectomy, and there are patients who are not really well suited for partial nephrectomy. And that's where we as the bottom feeders come in, and we're good at treating those patients. So we're a great alternative for that. Patients with solitary kidney, it's been shown to be very good. So keep that in mind. You got solitary kidney patients. I was looking for a great case to show you a post-partial nephrectomy embolization. Well, you guys have not given us very many of those. I had a hard time finding. I think we had one recently that was an arteriovenous fistula or aneurysm that formed that was like so slowly growing. We've even questioned whether it was a real thing. But we treated it. It was an embolization, very straightforward, went fine. Most of the time when we see post-partial nephrectomy hemorrhages, it looks like a trauma case. And for all intents and purposes, there's a little bit of bleeding in the kidney, that hematoma becomes larger, tears more stuff, and those vessels bleed more, and so on and so forth, and it snowballs into a much larger bleed. So this is kind of the same thing as trauma. So that's what I'm going to show you in lieu of you guys doing too good of a job. So this is a guy who had a fall from a ladder, fractured his ribs, and he had a CT scan done. He had tachycardia and hypotension. So we were asked to help. This is what his kidney looked like. Not good. This is the lower pole. The upper pole actually looked normal, with the exception of a little bit of fat straining around it. So we brought him to the angio suite and we did an angiogram. And this is what we typically see. Lots of little pseudoaneurysms, contained hemorrhages, and early venous drainage. So you can see the renal vein and contrast going up the IVC. Those are little fistulas. And so we start targeting those arteries with a microcatheter. So you see our base catheter here, that's a 5 French catheter. Then we put a 2 French catheter through that base catheter, and it goes farther out into the renal arteries. And we try to isolate the damage. We obviously don't want to embolize the normal parenchyma if we can help it. So here we are, pretty good position. We put some coils in. And so these coils are, I don't know if you guys have ever seen coils. It's a long wire that's shaped into it looks like a slinky. But when you stretch it out, it's straight. So you put that straightened wire into the catheter, which is a tube, and you push it. And when it comes out the other side, it takes its preformed shape. And so we have different shapes. Most of them are a ball. Some of them are a helix, like this shape right here. And so they coil up and they have little fibers on them and they induce clotting. So that's what it looks like going in. We coiled one artery and we found another that was still bleeding. So that's because we're being super selective. So we wound up embolizing. This is a total of 4 branches. We got rid of all the hemorrhage, and the upper pole of the kidney looks normal. This guy did really well.
You embolized any high flow priapism cases?
I have. Dr. Eustanzos over at UMC, he is our priapism expert.
Yeah.
And he and I used to work together, and we did a few of those cases together. He's really good at it. He knows when. So with priapism, you want to embolize enough that you cause occlusion of the fistula, but not so much that you cause decreased flow to the cavernosa. So it takes a long time to do it. We usually use particles for those because the fistulas are very small, not big enough to get a catheter into the fistula and put flow.
So you're the backup if he's gone to Turkey for 3 months.
Yeah.
He can call you.
I'm asking how soon can he get home, and I got to go read up on priapism. I've done a few, but not many. Yes, not a lot of people will do those. Just because it takes a long time to do it. You eject a little bit of particle, do an angiogram, see if you made any difference, see how the patient's doing. If not, rinse and repeat. You gotta do it a little bit more, a few more particles, see how the patient's doing, a few more particles. I have done an interesting case at UMC a few years ago. It was a young male in his early 20s who had a pelvic fracture and he had erectile dysfunction after a pelvic embolization, but he developed an arteriovenous fistula. So he said, well, let's go treat the fistula in the pelvis. And it was I think it was in the anterior division. And we embolized that. And he was given, what do you guys use to induce an erection, the ejection? So that's what you guys did beforehand. Nothing happened. We embolized him. Nothing happened. He went to recovery and he woke up screaming because now he had this erection for the first time in 6 months. And all the nurses, it was kind of a big to do. They weren't used to that. His mother was there. He didn't speak English. The mother was trying to say, my son's having an erection. Yeah. Kind of a memorable event.
Both vehicles in.
Yes.
The physicians that actually put the needles in and induced the actual fistula.
Oh,
And on both sides. And we still took care of that one, but we wrote it up. It was actually written in our journals.
okay.
Very interesting case.
Yeah, he's really good. He is from Turkey. He did a lot of that stuff in Turkey. He worked in I think it was the largest military hospital in Europe. But served, it was their quaternary, tertiary, whatever you want to call it, referral center. So it's kind of a big deal. He's very bashful and very humble. I think he was he was being considered for the Minister of Health for their government. It's like director of of their healthcare system. Yeah. So anyway, so that guy did very well. And now we're going to talk about prostatic artery embolization. How many of you guys have heard controversial stuff about prostatic artery embolization? How many of your patients have asked you about it?
I got asked for today actually.
And
I'm
I'm asking this question because people are coming to me, bypassing urologists, saying, I want this done. That's happening. And we need to know about it. I have done a total of, I think, 2 in the last 10 years. One of them was for hematuria. So that one doesn't really count. But I do have people that call me once a month asking if it can be done. There is a center that is coming to Lafayette. So there's a big urology practice in Lafayette. And this center is targeting, it's a national group called IR Centers of America. They also have Urology Centers of America. And it's a private practice, venture capital backed company. And so they're opening a center in Lafayette, specifically targeting prostate artery embolization. So it'll be here, and you guys are going to probably see stuff from it. So we'll talk a little bit about it and why people are asking about it. So it's technically can be a challenging procedure. We use all of our tools to help us do stuff like this. So what I mean by that is people come in, we would do this under, usually we do it under moderate sedation. So it's somebody who, let's say, most of these men have coronary disease, or they're not the healthiest in the world. And so we try not to put them under general if we don't have to. We do an angiogram of the pelvis. We'll access either the femoral artery or the radial artery. Depends on operator preference, what you're used to. And then we'll do angiograms looking for the prostatic artery. We'll do a cone beam CT, which is when our angio system spins around the patient. So it's taking x-rays from different angles like a CAT scanner, and it produces these images. So these are 3-dimensional images. They look just like CT images. The quality is not quite as good because it's not a dedicated CAT scanner, but it's pretty good. And we use this for a lot, like when I do all of my liver embolizations, I use this and we get outstanding, not only images, but better patient outcomes and long-term survival. So it's really useful. So we look for these arteries, and we have a computer system that helps us map the artery to the target. So it's better than a human at saying, this is the artery that's going there, because there might be another branch that's going there. It might have 2 arteries going to it. So we tell the computer that's the target. Here's our catheter, tell it how to get there, and it provides us a digital roadmap, virtual roadmap. And those are the blue and the green lines that you see. So then we advance our catheter and we do more injections as we get closer to it. And we're talking about a catheter that's 1.7 to 2 French, so less than a millimeter in diameter. We want it to be as small as possible to get into those arteries, but big enough to accommodate injecting particles. So the particles are 100 to 300 microns in diameter, so 0.3 millimeters. So pretty small. And then once we get into an artery that's very close to the prostate, we'll repeat our cone beam CT, making sure that we're not getting non-target treatment. So no penile embolization, no rectal embolization. This is a great image of the yellow arrow is pointing to a large prostate with perfusion, that's contrast going to it. This is just the left prostatic artery that's being injected. So there's only enhancement of the left side of the prostate. There is a rectal artery in orange red. And so the operators recognize that and they advance their catheter a little farther beyond the origin of that rectal artery, and then they did their embolization. So it goes, we have a lot fewer complications when we do that. Data. So this is supposed to be a slide that makes it look like there's a lot of data. There are 20 prospective studies, 6 randomized controlled trials. 4 of those are comparing prostatic artery embolization to urologic therapies. The other 2 are for, we're looking at different particle sizes and what's the best. So we do have data on this. IPSS scores we know go down. So we don't like measuring very short term, like 1 to 3 month outcomes for this, because we see initially some swelling. So the IPSS scores might not drop quite as much in the first 3 months. But long-term data, we've got up to 6.5-year data showing that this does work. It's not the same as a TURP, and we'll talk about that more in the future. But this data here, this is the largest study that's been done. It's been confirmed by some meta-analyses. PAE versus TURP. There are 3 studies looking at this, and all of them have shown initially TURP is much better. The 2 procedures do become statistically not different over time as far as IPSS dropping. Although if you look at the absolute IPSS scores, it's low. There's a bigger change for TURP.
We did get these scores, did get the flow rates, and then get the PVR.
Yes. The flow rates go down for prostate artery embolization, but not as much as TURP. And the flow rates go down more later. So after the inflammation has resolved. We're seeing flow rate drops from 3 to 8 milliliters per second, whereas for TURP, I don't know what a standard is. I did write one down, but it's a
You
lot.
mean flow rate go up?
I am sorry, flow rates going up. Yes. Flow rates go up way more, like double, like 45 milliliters per second versus.
What are the biggest concerns or adverse events that occur with?
So biggest concerns are, most common concerns, prostate or procedure time. So this takes like 3 hours to do. And it's technically challenging. Complications from the procedure, so ignoring the long time that it takes, rectal artery embolization, generally it does cause a problem. People have done studies looking at the rectum post prostatic artery embolization, and they do see small ulcers form. They're generally not clinically relevant. And then penile embolization is the most feared complication. That really, while we do see arteries going to the penis during our angiograms, we don't see embolization of the penis. And that's because there's collateral perfusion in that network of arteries between the prostate and the penis. And there's an inflow that protects it when we embolize. So generally, we do not see.
So ED, erectile dysfunction for a vascular defect.
And skin ulceration. Yeah.
A certain amount also with retention because of the edema that causes.
Yes.
They have had patients who have come to me.
Yes.
Said, I really couldn't be much for 3 months.
Yes, that happens. Some people will go ahead and put a catheter in.
Yeah.
And send them home on the with the catheter and tell them to come back to their clinic and void. That's pretty common. But there are people who do it without a catheter, and obviously you've seen that.
What's the, are they awake or sedated?
Moderate sedation, so Versed and fentanyl, they're kind of in la land. It doesn't hurt to do it at the time. Afterwards, it can be painful. I didn't mention that. Patients usually have a week of pain. And they take Percocet, and they take it every day. But after that week, it goes back to normal. So people will complain about that quite frequently.
3 hours. Some of our residents take 3 hours to do a turk, so.
Well, that's an average.
Everybody calm down.
Post-void residual, as you mentioned, this is so post-void, is definitely better for TURP. PAE, we don't see as big of a drop in post-void. But PAE versus pharmacotherapy. So PAE has been shown to be much better than in patients who are treated with alpha blockade and they're refractory to that. This trial was done with Flomax and Avodart versus PAE, and the PAE was statistically better in almost every way. It does have a role if the patient can't get a TURP. Let's say they're on aspirin and Plavix and they can't be taken off because they had a STEMI a month ago and you can't stop their dual antiplatelet therapy. Well, maybe that's a good patient for PAE.
And with the PAE though, even like sticking their artery, like you guys will do it on anticoagulation, no problem.
I would do radial artery, which we can do without a problem. Yeah, so that's how we would put in a coronary stent, or cardiologist would.
Is there any size restrictions for prostate?
Bigger is better. So prostate arteries are bigger in larger prostates, which makes it technically easier for us in many ways. A very small prostate would be a lot more challenging. So that's the other upside. TURP is going to be more challenging than a really large prostate. So there's a happy medium somewhere. I'm not, but those are things to consider. And I'm not asking everybody to send us PAs, but I'm educating.
I think you guys will.
Plenty to go around, especially if it takes 3 hours to get.
Yeah, well, no, people, so I had a guy come into my office in December and he was like, I'm not leaving until you agree to do a PAE.
The occupation will take 20 minutes.
Yeah.
So costs, people have looked at this and one paper reviewed PAE, urothelial lift, aquablation, water vapor therapy, and they found that PAE was the most cost effective if the 6-month repeat treatment rate was less than 2.3%. So this is an economic model. The 6-month repeat rate, people would probably just go onto a different therapy, but obviously that makes it not cost effective. But the point is, the cost is pretty similar between the therapies. I wouldn't use that as a driver from one to another. We're talking about over the long term, because if you do a urolift and let's say that has to be repeated, that's all factored in.
Insurance coverage PAE.
It usually
I thought that it like generated a lot of money for interventional radiologists compared to other.
So that it can. If you are not in a hospital setting and you own the building that you're treating the patient in, then you get both fees and you can make money on it. If you're fast. But for me, Tulane doesn't see that much more money. But yes, that IR Centers of America that's coming to Lafayette, that's what their venture capital.
There's one in the practice I'm going to. They have like an IR place and the guy does PAE and I watched him do one and he was talking about how much money he makes.
Yeah.
But then
That's not the guy you want operating on you, if that's what they're talking about.
no, that's not. I was as a resident, I was
Yeah.
like, I'm just curious, like what this, I was like, how much does this make?
Yeah.
Because is it, and he's like, well, that's like what does, but the
Medicare,
thing you were talking about is like people who can't come off anticoagulation.
yeah,
Is like, this is who I get referred to people who like can't come off anticoagulation. It's a great option.
Medicare pays about probably $11,000 for that procedure. Keep in mind, you also have to buy an angio system that costs you $1 to $2 million, and then you have to have people to run it. So if you do it right, you can make money on it, but
You
Not-
don't really want to.
I mean, it's a cool procedure from the standpoint that it's embolization, and I love that. But I could go embolize another organ. My most advanced liver embolizations take me an hour, so I'll settle for that. This is in our guidelines. It has a role in the European guidelines for interventional radiology. It's in the AUA guidelines. So are all of the other therapies. Interestingly, when we put guidelines together in general, we try to have a level of evidence, and then we have a strength of the recommendation. So the level of evidence is grade C, which the only other recommendation in the AUA guidelines that has better than grade C is TURP. And then it's got a conditional recommendation, which is similar to other therapies except for TURP. So TURP has the strongest data. I would have thought that this would be like level of evidence A, strong recommendation. But it's hard to do these studies nowadays, and get the numbers needed to really be statistically significant and powerful and ethical. So this is what we're going with. Conclusion, PAE, it is effective. It's good for large prostates. It's good we've definitely proven it's good in the short and medium term. It's not the best. We can predict what the patient improvements are going to be on average. And it's definitely better than medical therapy in patients who can't get other surgical therapies. The long-term outcome, not yet studied, so greater than 10 years. It's not out there. And we do see the need for retreatment in these patients. So that's what I have for you. We talked about all this stuff. We touched on angiomyolipoma embolization. We haven't talked about suprapubic catheter embolization or insertion. I did want to bring that up because what I like to do for suprapubic catheters is put in a Foley catheter. I usually use a council tip, put that in directly. I'm working on convincing the rest of the interventional radiologists to do that because I hate when people come back and have to have a pigtail switched out. So if you guys refer anybody for a suprapubic catheter, if you want to write 16F Foley,
Pigtails are horrible.
and if somebody says, I put in pigtails, say, well, I can't change them out. But the patient's got to come back to you, then just let me know.
I didn't know that we could put that recommendation.
Oh, yeah,
in, so.
that's why it's a consult. So you can say whatever you want.
So you
Well, you have that attitude. Not every interventional
urethral restriction patient, you cannot put a 16 time.
A urethral restriction, or I could put, is for suprapubic catheter. Yeah, we could put a 16 in.
Even in you cannot pass a catheter.
Well, so I don't need to.
Correct.
Because,
As a-
yeah, but a lot of people say, well, how can you fill up the bladder if you need to puncture it? We stick a little 22 gauge needle in it and inject.
So you're gonna do it.
I prefer to do that even if it's a normal urethra. But most of the patients, I just give them a bunch of saline right before. We have no problem. And we do it with ultrasound.
That's my hospital doing.
Any questions? Comments?